Good day, everyone, and in this lecture, we will be discussing how to help patients with adherence and their decision making. So, before we start, let us clarify two terms. We have compliance and we have medication non adherence. When we say compliance, this is the extent to which a person's behavior coincides with the medication or health advice. When we say medication non-adherence, this is the number of doses that was not taken or were taken incorrectly. So the difference between compliance and medication non-adherence is that compliance is a more general term for the person who is not following their treatment regimen. And for medication non-adherence, it is the specific term for missing out on doses intentionally or unintentionally. So the outcome of non-adherence should be our utmost concern. Pharmaceutical care requires the identification, resolution, prevention of drug-related problems. In particular, it could be taken in incorrect dosages or not even taking or receiving the correct drugs at all. So these are the most common problems you will encounter as a pharmacist. So what happens if the patient doesn't take their medications on time or doesn't take their medications at all? So non-adherence can result to undesirable outcomes such as worsening of the medical condition, increased admission rates in the hospital. It can also be death, and something less slightly morbid is inaccurate research data. So as you well know, persons who are taking their maintenance medication are taking the medicines to prevent hospitalization and the worsening of their sickness. Failure to do so usually results in more severe illnesses that will require more resources to treat. So the word compliance expresses a paternalistic connotation. So it's like a teacher to a student or a boss to a employee. So the word compliance may connotate that there is no place for patient's wishes. A patient just needs to follow the doctor's order. It also assumes that advice is always right for the patient's best interests. And you also assume that the correct disease, the correct drug, and the goals are achievable in this type of regimen. However, patients do recover on their own even without adhering to doctor's instructions. So this is one part in which you will encounter some patients that will say, my disease went away on its own even without going to a doctor or even without taking the doctor's medicine. Some compliant patients, on the other hand, may strictly adhere to their medication but actually get their diseases worse. And this leads sometimes to unnecessary prescriptions to placate patients. So we have some patients who are not confident in the medications that they are taking right now, and this may lead to unnecessary medications. We also have a type of non-compliance that is beneficial. So we also have intelligent non-compliance. So when we say intelligent non-compliance, this is when the patient stops when they are encountering adverse drug reactions. So this is the correct strategy if the patient is taking medicines and encounters something untoward, something new or something unexpected. So instead of taking the drugs continuously, they would stop and they would continue to and they would stop their medication and they would eventually go to the pharmacist or to the doctor. So instead of compliance, we should promote self-regulation. Instead of calling them non-compliant, we should call them non-adherent instead. So the goal here is to make the patient more active in their treatment protocols. It's because patients who have more control over their medication tend to follow their medication more faithfully. So what are the causes of non-adherence? So you might encounter patients who are non-compliant or non-adherent. Although you know in yourself that what's best for them is for them to take their medicine and eventually get better, sometimes our patients have other things in mind. So it would be our patient factors, belief, nature of communication, relationship between the patient and health provider, and behavioral factors. In terms of patient factors, the individual perception to the disease is one of the greatest factors to consider. It's because perception that the disease is worse than it is. Example is one way is hypertension. If they perceive that hypertension is lethal, it would actually lead to improved adherence. It's because the patient would be more scared or anxious about their disease getting worse. If the perception is that the disease is worse than it seems or less worse, it actually decreases adherence. Again, it depends on the person. We have persons who disregard health outcomes, and it actually leads to non-adherence because they do not believe that they would become one of those people who would need medication. So a good example of this is antipsychotics. So diagnosed mental patients could probably lie to themselves or refuse to believe that they have mental issues. And their non-acceptance of this fact may aggravate their non-adherence. They do not believe that they need medication because they believe that they are sane. Next issue or next factor is immediate threats to increase compliance. Take for example, hypertensive drugs versus anti-epileptic studies. So in this study, which is found in your book, persons taking antihypertensives do not immediately see threats to their health. Yes, their blood pressure rises, but it's not lethal as of the moment. However, if you ask a different group of patients, take for example our epileptic patients or our patients suffering from seizures, their perceived threat is greater because they have already experienced seizures, and seizures can be fatal in some cases. What if they didn't take the drug and they happen to have a seizure while walking down the stairs? It could be fatal for them. So the two groups of patients actually see their diseases differently, and it actually improves or lessens the compliance of our patient. Another one is the cost-benefit analysis of the patients. So take for example is a patient would bargain, not necessarily bargain, but weigh what happens if they take the medicine and what happens if they don't. Then they may actively choose to take medicine or they may actively choose not to undergo treatment. Take for example, a person who is suffering from psoriasis might not get treatment since there's little to no benefit for them. It's not life-threatening. It may be disfiguring, but if they don't care, they do not need to treat. Next is the perception of the condition. So take for example, acne and trenitoin. So this is common in teenagers in which skin conditions such as acne are common. And they perceive that having acne is disfiguring. So they are more compliant with dermal products and dermal treatments to improve their outer appearances. It's because they value their outer appearances. So they perceive that acne is disfiguring and they do not want to be disfigured. Therefore, they take medicine more. Next is perception of efficacy. So increased perceived effectiveness also increases adherence. So what does it mean? It means that patients who actually see the results actually adhere more. Take for example, you have another good example again is acne. if the person taking tretinoin is seeing that their face is clearing out of acne, they will continue to use the product because they see the outcomes or they can see progress. The same is true with the perception of friends and family, in which if family and friends comment on their behalf, hey, your skin is looking better, or good, it's good that you're growing hair back, it actually increases our patient's adherence. Next is communication factors. So communication factors is between the health professional and our patient. So if the message was sent, received, comprehended, retained, and believed, you actually improve compliance. Okay, if you sent the message, the patient received the message, the patient understood the message, the patient remembered what you said, and if the patient believed what you said, it all leads to increased compliance. Okay. However, if you did not say anything at all, well, don't be surprised if the patient did not comply, or if the patient did not understand what you were saying. It will not increase in adherence. And the last one, which is the most difficult, if the patient did not believe you. So supervision increases adherence. Patients adhere if patients adhere more if patients were given explicit and appropriate instructions, clearer information, and better feedback. So the more supervision is provided to our patients, the more that they are more compliant with their treatment. Next is content. What are you saying to our patient? Telling patients the possible side effects that causes, if you believe that telling patients the possible side effects causes non-adherence, that belief is false. Studies have shown that patients who are more informed about possible adverse effects are more likely to adhere more to the medication. It's because they do not fear what they are going into. If you know what you're getting into, you are starting to prepare yourselves and you're trying to commit to that treatment. Okay? Explaining the warnings and precautions actually increase compliance. However, do not try to scare patients if they are not compliant. Okay? If they do not comply, scaring them would actually worsen their compliance. Instead, focus on helping the patient make personal decisions on treatment and how to integrate it into their routine. Increasing the patient's knowledge, the disease and drug does not have significant effects on compliance. Increasing the belief and attitude does. So do not give a lecture to a patient about how the drug works, how it's made, what are the adverse effects, what are its adverse effects na rare. Instead, focus on making your patient believe in the power of the drug. If you are able to convince our patient that the drug works, it's more effective than simply informing our patient. Next is emotional content. Lower satisfaction with interactions lead to lower adherence. So if a transaction or a conversation between a patient and a health professional did not go as swimmingly as expected, it may have a negative effect on the psyche of our patient. Kumbaga, nasa loob. So, if they are not satisfied with the health professional, they may not adhere at all because they hold a negative attitude towards health professionals. Non-adherence is more prominent with patients' perception of unfriendly doctors and doctors who do not live to the expectation of patients. So, take for example, you had an encounter with a doctor in which they were rude or they were not welcoming as expected. Or if you had a high expectation for a recommended doctor, then you were disappointed with what you were counseled about, it may also lead to negative adherence. So non-adherent patients were less assertive, less friendly compared to our compliers. So in regards to a pharmacist's role in managing non-prescription drugs, patients are more compliant to introverted pharmacists. So non-aggressive pharmacists actually made better counselors than more aggressive pharmacists. Simply interacting with patients increases adherence. Patients that receive drugs from the pharmacist compared to clerks increases compliance by 25%. If you can see the importance of the pharmacist, if you introduce yourself as a pharmacist instead of being a pharmacy assistant, the patient is more likely to believe what you're saying. It's because you're a health professional, you're a licensed pharmacist, and they would believe what you say more compared to what the pharmacy assistant is saying. Another thing to consider is that showing concern also increases compliance. Being interested in the patient's disease state and showing that you care can have a positive outcome into our patient's compliance. Continuing, next we have behavioral factors. When we say behavioral factors, these are factors that involve decision making and experimental learning. So a good example of this is epilepsy. Why epilepsy? It's because persons who experience epilepsy are very adherent. It's because they have already experienced what happens if they fail to take their medication. If they fail to take their medication, they will suffer an epileptic attack or a seizure, and it's not a very pleasant experience. Sometimes patients may be non-adherent to assert control. Take, for example, dependent patients, like our elderly. The feeling of losing control might be a very negative experience for them, that the only way they can try to take control of their lives again is by not taking medicine. So there is weak evidence towards the knowledge on drugs and disease with compliance. So again, it's not about how well the patient knows about what they are taking. What is important is if they believe the drugs that they are taking. So some barriers of non-adherence. So these are the common issues that you may encounter. First of all, it may be due to complexity of medication regimen. So it's not always one tablet every 8 hours for 7 days. Not all medications will have that same signal. Sometimes you may take one tablet a day, another drug you may take twice a day. Sometimes, if it's a patch or a special dosage form, it may require more instructions for you to correctly administer them. So increased complexity of a treatment decreases adherence. Patients do not like to think too much. If they are bothered by the too many things they have to think about when taking medicines, they might not bother to take the medicines at all. Next is increased dosing. So the more a patient takes a medication, take for example 4 times a day, if you have a medication of 4 times a day, take for example ampicillin, it may decrease adherence because it's a bit too intrusive into your life. It may be due to that who wants to wake up at 4 a.m. to drink a tablet. That is why sustained release dosage forms were developed. The primary reason was to decrease dosing and to improve patient compliance. Another one is increased duration of therapy may lead to decreased adherence. If you want to compare a solid example, compare patients who are taking coamoxiclav 2 times a day for 7 days compared to a person taking Zithromax azithromycin, one tablet 3 times a day, you will most likely see that the persons taking azithromycin would complete their medication treatment or their medication regimen. It's because it's simple, it's short, it's easy to remember. Another barrier to non-adherence might be the presence of adverse drug reactions if the patient was not informed. Okay? If the patient did not expect this event, they would most likely be shocked or anxious, and it might scare them away from dealing with the drug itself. Next is difficulty of ADR. Take for example a very uncomfortable adverse drug reaction. Take for example, it leads to nausea and vomiting. No one wants to feel nauseous and no one wants to vomit. That is why the more harsh the ADR is, the more difficult it is to establish adherence. Take for example, if erythromycin. Erythromycin has a very low adherence rate because of its very unpleasant ADR. Next is when patients cannot understand the reasons for their medication use. It's either that the patient is in denial or the patient cannot fully understand at all. Like for example is our psychiatric patients. Next is difficulty accessing health professionals. Take for example, patients who are up in the sticks or persons who are far away from civilization, nasa bundok or nasa ating mga palayan, medyo mahirap makahanap ng ating mapapagtanungan. And finally is unable to use dosage forms. This is especially unique for patients who have special dosage forms like inhalers, suppositories, nebules, sprays, nasal sprays, drops. So next is patient decision making and empowerment. So how can we improve compliance? So to change non-adherent patients, you have to first understand the stages of change theory. So this is the 5 stages in which a patient prepares to commit to a certain change. So we have 5 steps. We have pre-contemplation, contemplation, preparation, action, and maintenance and relapse prevention. So when making decisions and reaching concordance, first you have to educate the patients about the treatment. You have to present risk correctly, and you have to use decisions aids like information about the clinical problem, explain the disease, options and outcomes, outcome probabilities, example of other patients, and guidance. So when presenting risk, okay, you might be tempted to use these words: very common, common, uncommon, rare, and very rare. However, all these sound the same to our patients. They just say it's unlikely. However, these are technical terms in which you have to differentiate each from the other. So very common is 1 in 10, while very rare is less than 1 in 10,000. Take for example, AstraZeneca clots is 1 in 3.5 million. So that is a very low chance, and it's not even within this official chart of adverse drug reactions. So you have to frame risk in perspective. A good example is a relatable event or something that is more relatable. Like for example, you have very common, the chance of getting a flu is around 1 in 10. Take for example is common or uncommon, the chance of getting a heart attack is 1 in 265. And if you want to deal with very large numbers, odds of winning the lottery is 1 in 13 million. So So next we have the presentation of non-adherence. So a good rule of thumb is to assume that all patients are non-adherent. The moment they come in through the pharmacy door, it's good to assume that they do not drink their drugs correctly. So to assess, you have to communicate, provide information, and you have to develop some strategies to prevent non-adherence. Simply pointing out that they are non-adherent only aggravates the problem. Hey, you're not taking this drug. You have to take this drug. That's not very helpful. What is helpful is to provide new information that may influence their attitudes and beliefs to increase adherence. So, in the provision of information, you have different steps or factors. First is your persuasiveness. Next is information regarding the use, information regarding illnesses and how medication can help, side effects, special techniques that they need to learn. Next is quantity and level. So in the communication, to some communication tips to prevent non-adherence. First is to engage the patient in conversation or in communication. You have to first establish a communication line before you can actually try to influence the patient. You can ask this by offering counseling or asking a few questions. So the tone of asking or talking with our patient should not be coercive, frightening, threatening, or demeaning. Most of the time, you will have to have a pleasant tone with a very welcoming nature. You should not insist that the patient comply. Don't say that you should drink this medicine because it's good for you, but rather convince the patient that you're going to have more benefits by complying to their treatment regimen than not complying at all. Convince the patient that adherence would be in their own interest, and you must not frighten the patient regarding ADRs or threaten them regarding the dangers of non-adherence. It's not good to scare our patients. The nature of the discussion should be in presentation of information. You should also involve the patient as much as possible in the interactions and discussions regarding medication use. When you're going to design a treatment plan, take the patient's needs into consideration. Next is the content of communication. You should inquire into the patient's perception of medication use to determine the types of information and behavioral strategies that may be of most benefit to our patients. Discover the costs and benefits perceived by our patient. Ask if the patient perceives any difficulty in taking the medication, and address any misconceptions that may arise and discuss thoroughly. Next is the frequency of communication. You should encourage future communication. You should tell them that the pharmacy is open anytime and you are happy to answer any inquiries they might have. Suggest that the patient call over the phone, over the pharmacy phone, to discuss any problems that may arise. Follow up with the patient's progress and continue to interact with them after the initial prescription was dispensed. And during refill counseling, explore any changes in the beliefs and perceptions. So in other countries, like in Qatar, someone has told me a story that they were prescribed medication, particularly antimicrobial. So I think it was for a wound or something. The pharmacist actually followed up with the patient. They're going to call, "Hi, hello, how are you? I just wanted to ask, how many tablets are left in your medication?" So from that, you can actually tell that the pharmacist is probing that according to the records, you should have this many tablets left. And finally, and next is the method of communication. Avoid avoid the use of jargons, match the patient's language and education levels. This pharmacy counseling for doctors is different from pharmacy counseling from non-health professional, and more so uneducated patients. You should use a combination of verbal and written communication, since this would most likely increase adherence. So here are some tips and strategies for preventing non-adherence. So working with a physician to simplify schedules, or by reducing the number and frequency of drugs, or to adjust dosing regimens to improve and accommodate our patients' needs. So if you need the doctor's permission to change routines, work with the doctor to simplify things for our patient. Supply medication reminders and organizers such as pill containers with alarms, organized compartments, and individual drug taking check-off charts if you can do so. Reminding patients through the phone or by mail about their prescription refills, like you're going to call their homes and, hey, your prescription is due for this week. When can we see you? Next is to enlist the support of the patient's spouse or family members to remind and encourage the patient to take their prescribed medicine. Next is, how can you tell if there is non-adherence? So we have two main methods of determining non-adherence. First is the direct method. So in the direct method, you rely on clinical indicators such as our blood pressure, serum levels, and clinical outcomes. So most of the time, you won't have access to this data, but what you have access to is our indirect method, such as pill counts, refill records, measurement of health outcomes. Like for example, you ask to get the blood pressure of the patient and it's not improving. Or if you ask how many drugs are left in your medication. Next is stockpiling. This is a part of the indirect method in which pill counts and in which you will notice that there's a lot of drugs. Like for example, you have 2 tablets daily for 7 days. For 1 month, you should have 60 tablets. And if you ask them how many tablets are left, and they said that there's still 50 left, then you have a problem. Another one is the toothbrush effect. In the toothbrush effect, it's when patients take their medication only before they go to the doctor for the checkup. So similar to going to a dentist, in which you're going to brush your teeth before going to the dentist, since the dentist will see them. It's similar here, in which a few days before, the patient would start taking their medications. Simply asking the patients regarding adherence can identify almost 80% of non-adherent patients. Okay, so if you have the book, you can refer to the table presented. So these are a set of open-ended questions that can give you information regarding the patient's status on adherence. Some factors to non-adherence. First is the patient, in terms of their knowledge, their attitudes, their values, their perceptions about their illness. Next is to determine if the patient has become apathetic, frustrated, or have lost confidence. So they may be depressed. You can advise them on what to do by seeking a health professional. Next is the medication. Assess the skills of the patient and how hard the treatment is to follow. Lack of availability of resources and services. Next is the presence of spouse, family, and peers who are near the patient that can help them adhere to medication by reminding them. And you should also examine the patient-healthcare professional relationship. Examine the relationship between the patient and the doctors and the pharmacist. Does the patient like you? Does the patient abhor you? Or does the patient hate you so much in which They will not drink the medication out of spite because of you. And in the resolution of non-adherence, the goal is that patients should receive their prescribed medication at the right time, the right amount, and the right intervals, while decreasing the side effects that the patient that the patient will encounter. So in changing behavior, the 5 steps, as we alluded to earlier, is pre-contemplation, contemplation, preparation, and action, and maintenance. So if the patient is still in the pre-contemplation stage, discuss the pros and cons of taking medication. Give your patients enough time to think about it. Next is to let your patient know that you're available to help. If the patient is now contemplating, help the patient articulate the pros and cons from their viewpoint. Provide further information and bolster their confidence by saying that you can do it. Preparation. Provide tools and skills for the next step. Give praise and encouragement, but don't treat them like children. And lastly is action. If you have solicited action from your patient, regularly assess and praise and encourage them. Finally is to monitor the patient. Monitor if they are continuously taking the drug. If they stopped or become non-adherent again, try to deal with it in a positive way. So some motivational methods you should use, some motivational interviewing techniques, discuss the benefits, risks, pros, and cons, raise the patient's awareness of body cues indicating the need for medication, explain how the patient can self-evaluate, and help the patient develop a coping mechanism. And finally, we have tools and techniques. So these are steps you could take. First is adherence aids like notes or treatment plans that are a checklist that you can provide for our patient. Next is to enlist support of a spouse or family member. If you can talk to them and gather their support to help them remind our patient. Next is to increase supervision. If you can call the patient once in a while, it would be helpful. Social service intervention should not be necessary in most cases, but if you're practicing abroad, it might be something to consider. If the patient couldn't buy their medication for some reason, you could call social services. And switching to alternative dosing schedules or dosage form. This is very helpful by simply adjusting when the patient starts taking their medication. It would be more, it allows the patient to become more affable to our treatment schedule. And finally is self-monitoring programs. If you can make a checklist of some kind or what the patient should expect upon their treatment, this consists of the self-monitoring program. And that is it for the lecture of our patients with adherence and decision making. So as the final word, not every patient you will encounter will be adherent, especially in older patients. If they are not adherent, you are not to scold them, you are not to admonish them of some kind. You're here to help. You're not there to demean them, you're not there to decrease their confidence. Even if they are not adherent and they are endangering their health or safety, it's your duty to help them become more adherent. And because of the benefits of adherence, it would lead to a greater quality of life for our patient. Okay, so I hope you have learned something from this short lecture, and hopefully when you become pharmacists, you would help a lot more people than being a ghost pharmacist. Being in the community helps more people than you actually know.